Okay.
Hello, everyone. Good morning, good afternoon, and good evening, depending where you are. Thank you so much to join us today. This is a ViewSonic Dialine Global Webinar, a platform with a mission to express and promote ultrasound usage in multiple clinical settings. For example, pain management, physical therapy, MSK anesthesia, and critical care. We have been working with many global experts with different specialties who give us lecture with different topics in this platform. And so far, we have done over 330 webinars since the beginning of 2020, attract over 100,000 physicians to join us, and over 1.6 million reviews and comments from our social media channels. So my name is Mike from the ViewSonic Medical. It has been a great pleasure to have two experts to join us today. Our new friend, Dr. George Chien, as the webinar speaker, and Dr. Andrew Juarez as the webinar moderator. Initially, Dr. George Chien will give us a lecture with the topic, Ultrasound versus Physioroscopy, Controversies in Interventional Pain Procedures. So I will introduce Dr. Andrew Juarez, and Dr. Andrew Juarez will give an introduction of the Dr. George for us and moderator the webinar until the end. So let me share my screen for introduction of the Dr. Juarez. Could you guys see it? Can you guys see it?
Yes.
Yeah. So let me continue. So Dr. Andrew Juarez, who is a specialist on anesthesiologist, he started his education from 2002 to 2007 in the Mexican School of the Medicine of La Salle University of Pain Physicians. And during 2008 to 2011, he continued his education of the anesthesiologist in the ISSE MYM Toluca medical centers. And finally, he finished his education from 2011 to 2012 in National Institution of the Cancer of Mexico. And currently, he got 5 certifications: anesthesiology, the pain clinical, palliative medicine, and the American Society of the Regional Anesthesia in Pain Management, and also the interventional pain sonologist of the World Institution of Pain in Miami, Florida. And currently, he is the staff in the pain clinical department of National Institute of Cancer, and the founding member of the Alive Pain Clinical and the Mexico Society of Ultrasound in Pain Management. And now let me turn my time to the Dr. Andrew Juarez to give an introduction of the Dr. George. Please go ahead.
Thank you for your introduction, Mike.
Thanks.
Let me share my screen. I would also like to thank Dr. George Chang, as well as ViewSonic Medical Company, for inviting me to be part of this project that allows to have access to valuable medical and technological information. It is a great honor for me to introduce Professor Chien, who is going to share a very relevant topic for all who study and perform interventional procedures for pain management. The title of this webinar, as you see, is Ultrasound versus Fluoroscopy, Controversies in Interventional Pain Procedures. And although Dr. George needs no introduction, let me briefly talk about the trajectory of our speaker. Dr. George is founder of the GCC Institute in California, which provides training in regenerative medicine and medical aesthetics. He's also director of pain management at Ventura County Medical Center and director of medical education of Advanced Regenerative Medicine Institute. He specializes in regenerative medicine and comprehensive pain management with expertise in PRP, BMAC, and ADSC. His medical training includes a fellowship at the Cleveland Clinic Anesthesiology Institute, as well as physical medicine and rehabilitation training at the Rehabilitation Institute of Chicago. Dr. Chang Chien has authored over 100 manuscripts on a variety of topics, including regenerative medicine, orthopedics, and advanced interventional procedures medicine, and has an active research in regenerative medicine applications for chronic pain. Finally, I would like to mention some of his qualifications and honors. Dr. George is CIPS certified by the World Institute of Pain and is an ABIPP examiner and Osteopathic Medical Board of California expert reviewer. The honors are many, but it is worth mentioning that Dr. Chang Chien received the American Society of Interventional Pain Physicians Outstanding Achievement Award in 2017 and the Rising Star Award by the same organization in 2016. And I now give the stage to our speaker, Dr. Chang Chien. Thank you.
Well, thank you guys so much. It's an honor to be a part of this meeting. Angel, you're very kind with that introduction. Thank you so much to WeSonic and the wonderful team. You guys represent a fantastic device and a company with fantastic support. Is my screen sharing already?
No.
Okay, give me 1 second. Let's see. Share screen. Give me 2 seconds. And is that up?
Yeah, we got
Okay.
it.
All right. So thank you so much again for the warm introduction. And hello to my international friends. This is a quick talk on ultrasound versus fluoroscopy. And it says controversies, but I think the whole point of this is just to challenge you to think about the way you're doing certain procedures already. And if there are other ways to do them that might actually be safer for the patients or actually even more efficient for the physician. So a lot of people who are trained on fluoroscopy always say, you know, why should I use ultrasound when I already have the C-arm, right? And the thing about this is that the C-arm, it does something to you. If you use it long enough, you end up only seeing bone. And you'll meet people who've been practicing for many years and they forget that there's all this tissue between the skin and that bone that might be pertinent and causing the pain. The other part of this talk that I want to bring up is really the idea for dual modality. And I think there's a big push for this where people are actually combining ultrasound and fluoroscopy, and in some cases in CT guidance to really, you know, again, optimize the positive attributes for each of these modalities. There's certainly going to be places where ultrasound is clearly advantageous for fluoroscopy, and certainly also places where, you know, I would actually prefer to have fluoroscopy as opposed to ultrasound. So both the modalities certainly have their advantages and disadvantages. Now, there's a lot of interesting examples that I'm not going to have a chance to go over every single one of them, but I want you to take a look at this list because I think these are really good instances, examples where utilizing ultrasound or ultrasound combined with fluoro is going to give you some distinct advantages. Now, here's a couple of examples that we're going to have some time to discuss, okay, during the course of this talk. So let's talk about the genicular nerves. The genicular nerves have been identified and discussed for many, many years. And it became sort of popular in approximately probably about 8 to 9 years ago when a paper published out of Korea talked about treating patients' status post total knee arthroplasty. Now, the thing about these nerves is that there's a huge variability, and there's really more than 3 nerves. And even in this slide, it's actually incorrect. It says at least 5. They have variable course, but if you actually look at Philip Payne's paper, which we'll discuss shortly, there's probably at least 15 separate articular branches that have been identified. So even with that being said, we actually have incomplete denervation to the joint. And a lot of this is really for this anterior knee pain. The awesome thing that people who do this have experienced is that, it's not only for people who have intact knees, right? If you have already had knee arthroplasty, you can still respond to this very well. So these are images that I found off the internet, and I've taken all identifying information away from this for who performed these. But to be absolutely frank with you, usually I ask people if I show them this slide, what do you think of these images? And I hate to say it, but when you compare these images to the original images from like the Choi paper in 2014, you'll notice that these needles are really not exactly where these nerves are described. And it's important to think about that because this might be more classically what people would want to place that needle along sort of where you have the shaft of the femur starts to flare out into the epicondyles. And the same thing for the tibia along the inferior medial portion. Now, one way to get around this that people have started doing is to actually use bipolar. But again, looking at these images, to be frank with you, I'm not exactly the most impressed. Now, that's from a classic way of thinking about it. Now, with some of the data that I'm going to show in a second from Philip Pang, I'm starting to look back and think, okay, maybe this will work. And let's talk about that for a bit. And why can we use ultrasound to help make up for that? So if you look at this image, again, the question is, where should we place these needles? And furthermore, why is the response rate to the block so high? And yet when we do RF, a lot of times people don't respond. You'll see that a lot of people would probably say that they would put the needles around probably about 2 to 3 or 2 to 4 on the upper left, or between B and C on the upper right, and probably about letter F on the bottom on the tibia. The thing about this is that when you just describe it based off of where there's this sort of flaring out between the shaft and the condyle, you notice that if you don't have a perfect AP, meaning if you just have a little bit of internal or external rotation of the bone, it can greatly change your perception of where that bone starts to change morphology. And then it actually makes your lateral quite challenging to really gauge a good depth if you don't know how to get a good lateral as well. So I throw this up there to remind people that they need to make sure that they're trying to get a true AP and a true lateral when they're looking at the knee. So looking at this top left, people are very familiar with this concept. The size of your radiofrequency lesion is going to be dependent on a few factors. Time being one of them, the size of your probe tip being another one. But although there's been a big push in pain medicine to just go towards larger and larger lesions with different technologies, be it cooled radiofrequency ablation or bipolar or excuse me, not just bipolar, but 2-tine or 3-tine radiofrequency probes. The reality is that larger lesions don't always compensate for poor technique, and they're certainly not going to be able to compensate for the ability to not be able to actually see the nerve. So for instance, if you look at this image on the bottom right, you'll notice that there's this, it's not pulsating, but it's an anechoic vessel right there in short axis, and directly adjacent to it is this hyperechoic honeycomb. Now what we have here is what they call a genicular artery. And now if this was the video, you would see that this is pulsating. Can you guys see my little mouse? I hope you can, but you'll see that this little thing pulsates, and then the nerve adjacent to it is usually how people say to find it. Now, if you don't have a good resolution, high resolution ultrasound machine, you might not actually see that nerve in short axis. And what you'll only see is that you'll see this artery pulsating. Now, someone will say, well, what I do, not what I do, but what people will say is, I say, well, I find where the artery is pulsating and I put my probe directly adjacent to it. The question is that if you're on the wrong side of the artery, you can imagine that you're not going to catch it at all. Now, the other thing that I don't know if you can tell here is that there's this periosteal membrane surrounding the neurovascular bundle directly adjacent to the artery and the nerve. And so what happens is that if you go down and touch bone and inject, and you see this if you do these under ultrasound, you'll see that the periosteal membrane actually expands away from the bone and it holds the injectate directly against the bone. What that also means, though, is that if you could be a centimeter, 2 centimeters away from the nerve and inject 1 milliliter of lidocaine and still get a positive response to your block, even though you were nowhere near the nerve. And so I think it's very important for this type of procedure to have good, to be able to actually visualize the nerve when possible, such that you can actually get good radiofrequency ablation following your diagnostic block. Now, for about a period of 3 or 4 months, I did go through the process of utilizing dual modality when performing this procedure. And you'll notice a few things here. I do show that, I have these nerves in short axis. Now, I have to tell you, I don't always see them there, okay? And it certainly can see them in different places. Fortuitously, in this example, it looks like the nerves are very classically where you see them, and I don't have it in this PowerPoint slide, but there's other instances where the nerves have not been in those classic representations. So one thing that I've done to get around that is that when I don't have an ultrasound machine available for me, I will end up having to do something like this, where I'll use bipolar radiofrequency ablation and burn multiple lesions along a strip lesion along the edges of the bone to try to create good coverage to try to catch those nerves. Oh, you know what? I don't have Philip Pang's slides in this talk. I apologize. So I'm just going to move on to cervical medial branch blocks. I apologize. Let me just very quickly. I just want to make sure I pulled up the right talk. Well, I guess I must have a newer version of it or an older version, so I apologize. I'm just going to go ahead and skip along to cervical medial branch blocks. Now, these are a common thing that we do. And classically, these are performed under fluoroscopic guidance. And there's the SIS approach is to come from a posterior to anterior approach, and you want to be sort of parallel to the waist of your the waist of the articular pillar, right? Now, the thing about these blocks is that, if you've been trained your entire life under fluoroscopy, you've probably never actually seen one of them. And you'll notice that it's interesting when you actually go and look at them under ultrasound, you can actually see within the valley, you can see the honeycomb of those nerves. Now, the other thing that I would caution people to be aware of, and that's why there's a good utility for using ultrasound in this area, is that it's not only that you can see the nerves, so that when you go to block it or when you do the RF, but you can actually see a lot of aberrant ascending cervical arteries that are not classically described because they're aberrant. They can be in one place, they can be another place. And I've seen, quite large arteries in this area under ultrasound that becomes quite surprising. So it's just something to think about. I think this is also an instance where if you have the time and the resources, I think dual modality is a fantastic option for this. Moving on to the pudendal nerve. I think this is an important block that really should be done under ultrasound. Now, this is an image, I think, from an ASRA publication, in a RAPM publication, Regional Anesthesia Pain Medicine. And you notice a few things here. There's the ischial spine on this left-hand side. And they demonstrate that the pudendal nerve is up here sort of floating in the soft tissue with the pudendal artery directly adjacent to it and the sciatic nerve just slightly medial and deep to it. And if you ever perform this procedure under fluoroscopy, I've moved on to the next slide, and this is all the images, and it's inverted or left to right, right to left. But the way this is described under fluoroscopy is really to get a nice AP or PA image, and you take your needle tip and you really just make contact at the ischial spine. At the tip of the ischial spine, you inject contrast to assure that you're not in the sciatic nerve. You contrast and ensure that you're not in the pudendal nerve or the pudendal artery. And then you can do your injection. Now, you'll notice how in this image, the ischial spine is right there in the what they're labeling as the pudendal nerve is sort of, again, off in the soft tissue floating in space. And this STL is the sacrotuberous ligament, and the SSL is sacral spinous ligament. And these are the ligaments that essentially bind the pudendal nerve in this area. And the reason why this is important is because if you ever want to come back and not only perform a block, but actually do maybe pulsed radio frequency ablation, it's best to really be able to see the nerve so you can identify where you want to do the procedure, as opposed to sort of hitting that bone and doing a field block, or hitting that bone and then using stimulation to try to identify where the nerve is at. And I think, again, this is important because there's been case reports where people have done sciatic nerve blocks from a posterior approach and even and accidentally hit the pudendal nerve. And there's been case reports where people have gone after the pudendal nerve and created injuries to sciatic nerve. Again, I think because the course of even the sciatic nerve can be can change, and you can actually, there's cases where it move much more closer to the ischial spine and go over the bone. I think it's just an important thing to do, especially if you're performing this type of procedure under sedation. So moving on to stellate ganglion blocks. And I apologize, I guess this is a much shorter talk. I had more slides for other types of procedures that I was going to cover. But I think the stellate is a really good instance where we can talk about how the combination of ultrasound versus fluoroscopy can make, there's controversy with this. For instance, when people perform this procedure under fluoroscopy, there's two primary approaches that people do this. There's sort of this standard AP approach where patients lying face up, and you'll take your needle and move it essentially adjacent to the uncinate processes. You can do this at the level of C6, or probably a little bit more controversial, you can do it also at the level of C7. Now there's a chance for hitting the vertebral artery at that C7 because it's not protected by the anterior tubercle of the transverse process. And so these are some of the ways that people go about doing this. Now, a lot of times though, when you're doing this procedure under fluoroscopy from AP approach, people will say you're going to go down, you hit bone, you may or may not pull back on your fluoroscopy, or excuse me, your needle, an arbitrary distance, inject contrast such that you see what essentially is an outline of your longus colli muscle. Now, a lot of times what people are probably aiming for is to try to get an outline of the outside of the longus colli muscle as opposed to inside of it. And that's supposed to demonstrate, therefore, that you're actually in the what's called the prevertebral fascia. Now, the other way of doing this is actually an oblique approach, which is described by Nilesh Patel. And I think I have some images of that. So again, I've already kind of described this. Now, again, under fluoroscopy, really people only have two ways of performing this procedure. There's what's called the anterior approach, and then there's also the foraminal view. And I have images that I'll show in a second. Now, when I teach this procedure and when I perform this procedure under ultrasound, which is really my preferred way of doing it, I actually have 4 separate approaches when I'm utilizing ultrasound for a stellate ganglion block. And I think it's important to have different ways of doing it because it's going to be dependent on the anatomy I see during my pre-procedural planning and scanning. So again, what are the multiple anatomical considerations that I have to be concerned about here? Well, I could go through the thyroid, which honestly we want to avoid, but it's safe. But what can be there? You know, you can have incidental thyroidal cysts that might get in the way and might confuse you when you aspirate or when you inject. There's a possibility that you could cause one of these to burst. There could be other thyroid pathology, possibly neoplastic, that you may or may not want to be wanting to put a needle through. Certainly, there could be vascular. The thyroid is a highly vascular structure, and people can have AV malformations, thyroidal arteries, and the esophagus can also be in this way. The Koreans describe the transjugular approach, which I think is a good way of doing it as well. You essentially go down, you find the jugular vein, and you compress it, and you take your needle and you go through and through it. Now, this isn't, the one caveat to this procedure that I found is that a lot of times the amount of pressure you need to compress the jugular vein actually has a lot of causes pain and discomfort for the patient. So they really cannot tolerate for very long. And then sometimes it causes them to want to swallow, like almost like a gag reflex. And then that can cause the tissues to move as well. Now, the positives for this approach is that you're not going to have ascending cervical arteries or cervical nerve roots running through your jugular vein. Okay, so you can avoid them by going through the jugular. Now, let's talk about what's the lateral or even the far lateral approach. This approach, you're going to have to pass by or even over or under oftentimes the cervical nerve roots, because they've already exited the foramen and are starting to descend to create the brachial plexus. You have to pass by the anterior tubercle. You have to go over that hump and get over it. And then again, in this area, there's ascending cervical arteries. And then you also want to make sure that you're being cautious and wary of the superficial cervical plexus. So again, the goal here is to inject into the prevertebral fascial space superficial to the longus coli. And that's actually a space that we can identify readily under ultrasound. Again, here's the superficial plexus. And I think people have a tendency to forget this, and it's very superficial, but it runs directly in this area. And so you want to be cautious of hitting one of these nerves. Okay, so what does this look like? So what we have here is we have the trachea, and that's midline. And if we're scanning, so obviously trachea is midline and medial, and going off to the right-hand side of the screen is lateral. And we show the thyroid tissue here. We have the esophagus here, and the longus coli, which is usually going to be seen on top of the transverse process and deep to the carotid artery. A few things you should be aware here. One of the things that I like to do if I don't readily identify the esophagus is I ask the patients to swallow. And you can see that when they swallow, the esophagus will tighten up and move. And a lot of times if they swallow saliva or even air, you'll see a flash of hyperechoic air within that esophagus. The other thing that I want to point out here is that a lot of times there's an artifact here deep to the carotid artery, and very commonly people will mistakenly call that hyperechoic artifact deep to and you're going to have this deep to any anechoic cyst or vascular structure. But people will misidentify that and call that hyperechoic area actually the stellate ganglion, which is not really what it is. So here's one way. This is sort of the lateral approach. Now, looking at this again, we have on the left-hand side is midline, and we have the trachea there. We have a thyroid with incidental. There's two anechoic spots inside this thyroid. Those could be cysts. This isn't my image, but those could be cysts. Those could be some blood vessels. Keep in mind that the inferior thyroidal artery, which again is a big artery in this area that you don't want to hit, has what is called a serpentine course, meaning it kind of traces back and forth. And that's certainly something you don't want to hit. Now, you'll see here that the longus coli is deep. The IJ is right there. The SCM, the sternocleidomastoid, is superficial. And they're showing the goal here of getting this needle path essentially. In this image, the dots actually run straight through the IJ, and it runs through sort of a superficial area of the IJ, which would be kind of worrisome to me because it's almost like you're shearing it. So I wouldn't recommend that kind of approach, but you could make sure you go underneath it. And again, we see the longus coli muscle there. And the target of this injection would be to be superficial to the longus coli. You're going to have to navigate this thin space between the IJ and the anterior tubercle of this level, which is probably looks like it'd be like C5 or C6. Okay, and again, so if that's your target, can we go straight through the IJ here, or could we even go from a medial to lateral approach, avoiding the carotid artery and going straight through the thyroid, right? So again, that yellow line is, if I was going to come from a lateral approach, I would probably do that. Looking at this patient, you can imagine I would pick one of these two approaches, utilizing either that aqua green line or the yellow line based off of the anatomy that I see here. And again, here's that far lateral approach. Again, you're going to have to traverse a longer distance, but you want to make sure that you have good control of your needle, and you're also not hitting cervical nerve roots as they exit in this area. Okay, so again, here's just the same anatomy. This is just looking at some of the other structures in this area, scanning from a little bit more further laterally. Again, you have the anterior the ASM, you have the brachial plexus between, you have the medial sternocleidomastoid muscle. And again, so if you're coming from the lateral approach, you might end up going through the brachial plexus. So you just want to be very cautious about where your needle path is going. And that's why when I do this procedure, I really want to have at least 3 or 4 approaches that I'm considering when I'm doing this. Again, my target is here, but there's all these blood vessels in this way. And so you really want to be cautious about where you're going from. Now, the beauty of doing this procedure under ultrasound, again, as opposed to doing it under fluoroscopy. Keep in mind, fluoroscopy, we can't see these structures. So we're just going straight down, we're hitting bone, and we're injecting contrast, and we're just believing that that's good. You can imagine, you see this red line here, actually directly in our ultrasound, you can actually come in, go through the SCM, go through the ASM, and completely avoid these structures by taking your probe and by taking your needle and leveling it out, advancing it, and then moving it around those structures. You can also hydrodissect as you're going down with 1% lidocaine, and it'll push those structures away. So again, it's a very dynamic process and a very dynamic way of doing procedures. These are just images. This is that traditional AP approach, just taking that needle and dropping it along the side of C6 or C7 and making sure that you don't have any vascular flow. This is the Nilesh-Patel approach, which I think would be my preferred way of performing this procedure. You oblique it to get a foraminal view. You want to make sure that your end plates are squared off, and you put your needle, essentially, if you imagine the cervical vertebral bodies are shaped like a flag. Once it's squared off, you sort of just go for that top right corner and put your needle there in this foraminal view. Again, you don't want to be too far posterior where you're getting really close to the near foramen, as those cervical nerve roots are going to come out and descend, but also move anterior. Okay. Fluoroscopic approaches, again, for this procedure is depending on touching Oz. For safety, you have an arbitrary retraction of the needle. You're typically going to require higher volumes of injectate. It's much less specific. And the reality is that you cannot anticipate, visualize, or avoid sensitive structures due to anatomical variability. Now, I have other slides. If you guys will bear with me, I can pull them up, but I want to talk about the role of ultrasound guidance replacing open surgery. And there's a couple cool examples for like pulley release and transcarpal ligament release and carpal tunnel syndrome. So if you just bear with me a second, I'm going to pull that up. Unless, Mike, we're not doing well with time. Interesting enough, I thought that was, nope. Sorry, you can tell there's a lot of talks on my Maybe this is it. I apologize to all my friends in the international who are watching this. Okay, no, that's the exact same talk. Well, let's open it up now. Are there any questions while I pull this up? Mike, Angel?
Hello?
Hi, I'm trying to pull up.
Hi, George. Yeah, yes, we are looking, we have some questions.
Okay, go for it.
Can we begin with a question?
Yeah, please.
Okay. The first question is based on your talk. Would it make more sense to perform pudendal pulse radiofrequency with ultrasound versus fluoroscopy?
So the question is, does it make more sense to do pudendal pulsed radiofrequency ablation? Here's my talk, by the way. I found it now. I apologize. I pulled the wrong one earlier. Does it make more sense to do pulsed RF of the pudendal with ultrasound versus fluoroscopy? I really think that you can use both, but really for this type of structure that's floating in the soft tissue space, I think seeing it with ultrasound is much more powerful, because not only are you seeing the nerve, but you're also avoiding some of the structures in this area, the pudendal nerve and the pudendal artery, or excuse me, the pudendal vein. And more so, I've also found that nerve stimulation really is not the most dependable, because for these somatic nerves, you're just trying to stimulate. You're asking the patient, do you feel it? Where do you feel it? Does this reproduce the areas you're in pain? And sometimes they get very confused with that. And so, using fluoroscopy, even with the addition of nerve stimulation, I find is much less dependable. So yeah, I'm going to have to say, I think really I would go with ultrasound.
Okay.
So I found some of these slides. I'm going to just come back to this really quickly. And I apologize that this is very disorganized. It's because I pulled up the wrong PowerPoint. But I just want to show this. This is, I do a lot of regenerative medicine with PRP and bone marrow and things like that nature, and even prolotherapy with dextrose. And this is a facet capsule, right? And I just want to show you how this is done. You notice performing facet injections under ultrasound really are very, very simplistic, very quick. You'll notice how widened this facet is, and you see the injectate flow directly in. I can target, treat 3 or 5 levels in the C spine rather safely, from C2 down to C6, really in the course of like 5 minutes. And under ultrasound, I can treat within the capsule and also treat the capsule itself. And so you can see it's quite a simple thing to do. Here's just a different level. You see again, or actually that's the same one, but it flows directly in. So it's very simple. I did file the rest of my slides. I want to show you this. This is the A1 pulley for trigger finger. And you notice the pulley is right here. And the pulley normally has what's called a trilaminar appearance, meaning it's got 3 layers. It goes hyperechoic, anechoic, and hyperechoic again. And you'll notice that this pulley is quite thick, and when the patient moves his finger back and forth, it rubs and it catches right here, and it causes a focal tendinopathy, this thickened area in the tendon right here of the FDP. And on this right side, what I've done is that I've gone first in short axis, and I don't have the long axis videos here, but you notice there's something going on here. You see that's my needle. It's an 18 gauge needle that I've bent, and I'm actually going through that area. I've injected, but also using it essentially like a small 18 gauge surgical scalpel. And I'm essentially doing a percutaneous surgical release just with local anesthetic. Again, you'll see again my needle going in and out. And based off the way the fibers are going, you don't want to just go in short axis. I do it first in short axis to sort of open it up, and then I go back in long axis, and you can cut across those bands. And obviously you can see on this bottom right-hand side, this is not the most expensive of surgical equipment that I'm utilizing here. Very quickly, if you see patients who've already had carpal tunnel release, you'll notice that the traditional way of performing this results in quite a unsightly scar across the base of their palm. There have been advances where people do endoscopic carpal tunnel releases, but that actually requires a high level amount of training as well. And more recently, there's percutaneous ultrasound guided ways of doing this as well. Now, a number of years ago, I started doing this where not only did I do the carpal tunnel injection, but I started, once I've created a space for myself surrounding the median nerve such that I had enough injectate in there, And here's the teaching point about this procedure, because if you look at a lot of papers looking at this, they'll say that, you don't want to inject a lot of fluid there because they're scared of creating more compression in the median nerve. And I used to have that fear of that until I started injecting more and more fluid, and I realized that it really didn't do anything except allow me to have a working space around my median nerve. So what I'm saying here, and it's depicted in these images on the bottom right, is that once you get into that space, you can inject directly around it. And once you get up to the top, like C and letter D, you'll realize that you have space that you can work around the median nerve. You're not going to poke at it. And you can come back in with an 18 gauge and go in this plane, which is really in the direction of the fibers, but you also need to come back and cut across them as well, essentially long axis to the median nerve. But I found that this is actually an approach that can be utilized to save patients from undergoing open surgical dissection. Here, let me just show you what it looks like when you're injecting. Right, you can dissect and peel away that median nerve from the transcarpal ligament, and it'll stay away from there, opening up a nice space for you to work in. So what else is out there now? Okay, so there's devices that you can go and get trained on that are essentially like a reverse scalpel. And they utilize different things such as the balloons. I'll just show you what this looks like. You identify the transcarpal ligament in your safe entry zone, and then you have this thing that deploys a balloon that opens up a safe space by pushing the tendons and nerves away. Now, this is a video of what this looks like. You have to admit, that's pretty cool. So very quickly, I'm talking about a few quick cases. I think just one last case, and then I'll be done with my talk. This is heterotrophic ossification. Once it's completely matured, is actually a surgical, typically managed by surgery. Now, this is a patient of mine who had lateral knee clicking, and he was a fighter, began at an early age. He was kicked I think he was practicing Taekwondo at the time. And every time he says he would bend down, it causes palpable click on the lateral side of his knee. And ultrasound evaluation, I found a mobile bony mass that's very well circumscribed. And I can tell that when he went to stand up and he moved from essentially flexing the knee to extension of the knee, it was essentially catching under the lateral side of his iliotibial band. Now, looking at this bony structure, I took a needle, and you can see that I can move it along the top side of his bone. And although I don't have an X-ray to look at this piece of bone, it's important to understand that you have to have a wide differential just to make sure that this is HO versus something a little bit more malignant, like potentially neoplastic. But it wasn't attached to his bone. It wasn't an outgrowth of his distal femur. And he was adamant that he did not want to have surgery. And part of it was vanity and part of it was insurance. So he asked me if there's something I could do for him. And really, quite simply, I just did the same thing. I took that same fancy 18 gauge drawing needle, and I went and I performed barbotage of it. And I just barbotaged it until I broke off most of it and then fragmented into little pieces. You'll see in this image that there's all these hyperechoic spots that are sort of scattered in the soft tissue around it. And again, it's going to cause an inflammatory process actually afterwards, which he did have, and I treated with corticosteroid injection. And afterwards, he had complete resolution of all these issues. So again, although I didn't remove the piece of bone, I was able to break it down and shave it down, and even more than even in this one image. But to a point where it was no longer symptomatic. Again, it saved him surgery of something I did in my office, and probably only took about 20 minutes. Okay, and this is just a slide from the Taiwan Pain Society meeting. that I think some of these slides were originally set up for. So that's that. You can follow me on Instagram if you'd like to. My name is Regen Med Doctor. Thank you so much for your time. I'm going to unshare my screen, and let's see, how do I unshare my screen?
It's on the bottom of your screen. There's a share screen. You can just end it.
I think we're good now, right?
Yeah. It's all right.
We'll open up to any questions.
Thank you, George, for such enriching presentation. We are now continuing with the questions made by our participants. The next question is, what do you think is the safest way to perform these complex procedures?
You know, the safest way is probably going to be different for every single procedure. You know, I think the most important thing, which always sounds like really obvious to people, is to just get good training. You'd be surprised, you know, if you teach a lot of cadaver courses, you'll see the way people do things, and you realize that it's not that we can't all do things a little differently, but there's definitely the safest way, I think, or what's probably the most optimized for safety. And so number one is obviously get good training. I think dual modality is an option if you have both of them. If not, a lot of times using ultrasound, I think for most of these procedures is probably going to be, for many of them, it's probably going to be much safer than fluoroscopy, although it's going to be hard to prove that, if that makes sense. It's going to be hard to prove because people aren't really reporting their complications. And the reality is the complication rates are quite low.
Okay, thank you. Let's continue with the next question. The next question says, I have performed stellate ganglion blocks for many years using fluoroscopy only. Do you think I should switch?
Wow, that's a complicated question.
Interesting. Yes,
yeah, that's an interesting question. You know, so you know, the classic way of performing, you know, even before fluoroscopy and image guidance, you know, people were saying, hey, you know, I would touch down and pull aside the soft tissues, you know, make contact with chastognax tubercle with my fingers and just inject a large volume of medication. You know, something as an analogy to that is that when they first started doing fluoroscopy for epidurals, the criticism from the older attendings, or the older anesthesiologist, was that, didn't we teach you how to feel for loss of resistance? And then the studies came out in, I think, the early 2000s that showed that they had false loss of resistance, and they weren't really in the epidural space probably about 40% of the time. So now, what does that mean in this context of this procedure? I think the reality is that complication rates are quite low. And if you're comfortable doing them with fluoroscopy, I don't think there really is, it's fine. And especially, I think, even if you adopt, especially if you adopt the foraminal approach that Patel wrote about. Now, that being said, though, every time I take one of those people and I say, well, let me show you, let me look at your neck under ultrasound and show you what is there in this area and what your approach really is going through. I think people are shocked. And then I ask them, well, what do you think? Would you rather someone do it with ultrasound or fluoroscopy if you ever needed one of these? And almost universally, they say, if it's on my neck, I'd probably want you to use ultrasound.
I agree with you, George. Our next attendee says, may I know what is your success rate for transcarpal ligament release using this percutaneous approach?
You know, that's a really good question. Yes. I'm certainly not a surgeon, and I don't mean to make it sound like this is a replacement for a completely open surgical approach. I have had referrals. I work closely with a hand surgeon, and he sends me patients for carpal tunnel injections. And there have been patients that I have, while I'm in there, I say, well, let me just try this for you. And this is obviously anecdotal. I can tell you that, you know, in the past 6-7 years, I've probably had at least, I would say 10-15% of patients that I've done this that have said, hey, I don't want surgery at all, because this was good enough after just one time of doing it. Now that's relatively low. I don't actually perform it on all the patients because I'm not trying to, I don't know how to say it, but yeah, a lot of times I just do the block because that's what they're referred for, if that makes sense. There are patients who come and they ask for the block because they're not surgical candidates, or there are patients who have had where they've had surgery on one side, they continue to have symptoms, and then they say, you know what, I don't want to have that surgery yet. What else do you have for me? I've certainly found success with that. So I can't give you a hard number, and I don't want to make it sound like it's better than it is, but I think it's a good option that really takes only a few minutes. And it's percutaneous, there's very little side effect and harm in trying this as long as you're very cautious about what you're doing.
Okay. We have another question. Say, hi, doctor. What resource would you recommend for improving my procedural ultrasound skills?
That's a great question. You know, there's nothing that beats hands-on work. There's a number of great organizations out there. I think if you're in Latin America, and even if you're not in Latin America, there's a fantastic organization called SMUD, S-M-U-D. I have some good friends that run SMUD. I would like to give a shout out to them.
Yes.
But you should look into that. They run multiple workshops in Europe, and primarily in Europe. There's the Pain School International with Dr. Aggie and Dr. Trescott and Fabricio. I think the World Institute of Pain does fantastic meetings as well. So I think these are great things. If you don't have access to that, if you're in a country that doesn't have money to go to one of these meetings, you know, practicing at home is fantastic. YouTube has great resources. I would get some of these books by Bianchi and John Jacobson, read them. I'm sure in China they have fantastic courses as well. I definitely know in Hong Kong I would go and visit Stanley Lam, but you know, try to work with some of these people because they'll give you really good one-on-one training.
I have one question.
Sure.
The last question maybe. Sometimes we do the procedures ultrasound guided, and finally we collaborate with the C-arm. What would you recommend to us if the final position of the ultrasound is not the same that you look in the C-arm?
You know, it's funny because when we use, I've done that, and if you're so trusting in the C-arm image, a lot of times. So I can tell you something. It's a little bit funny story, and I know I always digress, but one of the first times I did a stellate ganglion block under ultrasound combined with fluoro, I finished the block and I was holding the needle the entire time, and it was directly underneath the carotid artery, right on top of the longus colli. And I was very happy with the image under ultrasound. And even holding it with my hand in the image, I said, picture. And the needle looks so medial compared to where it's supposed to be under fluoro that I actually got scared and pulled it out. Okay, it was so medial compared to where we normally think is okay. I literally pulled it out. And I think back and I said, why did I do that? Because if I just did it under ultrasound, I would have been very happy with my procedure. And I think you have to trust yourself, because again, that fluoro guided image is very static. You know, it's going to look almost the same. If we took everybody who was on here, all the participants, and we did an AP image of their neck, it's almost always going to look exactly the same. But if we did ultrasound of just 5 of these people, we're going to have completely different anatomy. So, you know, obviously you want to use your best judgment and with the modalities that you have. But I think, if you can see a whole lot more with ultrasound, I think that's the way, really, that's becoming the standard of care for performing, or it should be likely the standard of care for performing stellate ganglion blocks.
Thank you, George. I think we don't have any questions.
All right. Thank you, George. It's a great lecture. Thanks a lot. And thank you, Andrew. Thank you for moderating the webinar. And I think we come to the end of the webinar. And
Fantastic job.
I would like to thank everyone to join us and be a part of such a great experience. And
thank you.
thanks. And for the continued learning purposes, we will post this video on our social media channel like YouTube for someone may have still interesting to learn again. And I welcome everyone to following us on our official website, weson.com, and our social media like Facebook, Twitter, and Instagram, something like that. And please stay with us for the future webinar. And thanks all. Thank you, George. Thank you, Andrew. I see you next time.
Thank you both. Everybody have a wonderful night.
Yeah, you too. Have a good night.
Bye-bye.
Thanks. Bye-bye.
Saludos a los de que hablan español también.
Bye-bye.
Bye.
Gracias. Thanks.
Thanks.